So we're going to move on to the second talk of our session today, which is on another topic that, again, we all encounter very frequently in our clinical practice, which is management of the pregnant IBD patient, which is challenging and frightening, but often very rewarding as well. And we have Professor Catherine Nelson-Piercy from the Imperial College in London joining us. Professor Nelson-Piercy is an expert in the management of complex medical conditions in pregnancy and has published widely on that topic. And we're delighted. Her primary training is in obstetrics and in managing disease during pregnancy, so we're delighted to get her slant on a problem that we deal with on such a regular basis. So we look forward to the talk and to taking some questions from her afterwards.
Hello everybody, and thank you for asking me to speak at your meeting. My name is Cathy Nelson-Piercy and I work as an obstetric physician in London. My title is Managing the Pregnant Patient with Inflammatory Bowel Disease. These are my declarations of interest. I'm going to divide the talk into fertility issues, pregnancy outcome in inflammatory bowel disease, drug safety in pregnancy and with reference to the recent guidelines, delivery and obstetric issues, postnatal care, surgery and imaging, and lastly, contraception. Firstly, a talk about fertility. There are many reasons why fertility rates might be lower in women with inflammatory bowel disease. It might simply be related to their age. Chronic inflammation related to active inflammatory bowel disease. They may be underweight. Patients with previous pelvic sepsis may have tubal obstruction. There are some data referring to an increased risk of infertility in patients who have undergone pouch surgery. And then there are issues related to decreased libido, dyspareunia, abdominal pain, anxiety, and depression. These are data taken from a Danish database examining time to pregnancy, and you can see it's a large data set, and it shows the adjusted risk ratio for a prolonged time to pregnancy, in other words, taking more than a year to become pregnant, shows that the risk of this is higher with inflammatory bowel disease, but this is only significant for women with Crohn's disease. And it's particularly the case that fertility problems are more likely in women with Crohn's who've undergone surgery prior to attempting to conceive. In a larger meta-analysis of 6 studies looking at fertility before and after pouch surgery, these were mainly ulcerative colitis patients, and the infertility rates were quoted at 20% pre-pouch surgery and 63% after IPAA. Giving you a relative risk of fertility problems after IPAA surgery of almost 4. But importantly, assisted reproductive techniques after pouch surgery have good success rates. This is a large meta-analysis of 10 studies, again looking at the impact of surgery for IBD on fertility, and it found that if you looked 6 months after, infertility for 6 months, if you look before and after surgery, then the rates of infertility are higher after IBD-related surgery, 60%, 63% and 70%, depending on what time period is taken after the surgery. Previous surgery is well tolerated in pregnancy, so women with ileostomy, proctocolectomies, ileoanal anastomosis and pouch surgery can all successfully carry pregnancies. For your patients with ileostomies, they often have quiescent disease and can have a full-term normal vaginal delivery. Occasionally we get problems with intermittent intestinal obstruction. That's normally in women who've had that problem before pregnancy, and as the abdominal wall stretches you can get some peristomal cracking. I'm now going to move on and talk about the effect of IBD on pregnancy outcome. And to do this, I'm going to use this study, which was published 4 years ago now, a large data set using the GP research database. Almost 2,000 women with inflammatory bowel disease, divided up into Crohn's and ulcerative colitis. And I'll show you the raw data, but the headline from these studies is that Crohn's disease is associated with an increased risk of preterm birth and low birth weight and postpartum hemorrhage. The risks are lower with ulcerative colitis, and these risks remain independent of the mode of delivery. Prior surgery did not increase the risk of adverse birth outcomes, and women with IBD were more likely to have a caesarean section. So firstly, if we look at the risk of preterm birth, this column shows you the control population where the risk of preterm birth is 6.5%. This column is IBD cases lumped together. This is Crohn's disease and ulcerative colitis. Here we see the risk of postpartum hemorrhage is significantly higher in Crohn's disease, but not ulcerative colitis, and importantly, venous thromboembolism. All pregnant women are risk assessed for venous thromboembolism, and we know that active inflammatory bowel disease is a risk factor. Women with Crohn's are more likely to have an elective and an emergency caesarean section, but not women with ulcerative colitis. And as has been shown on the previous slide, the risk of preterm delivery is higher with both Crohn's and ulcerative colitis. And with that, the risk of a low birth weight baby, less than 2.5 kilograms. So I'm now going to discuss the guidelines, the ECHO guidelines and the Toronto Consensus guidelines. These ECHO guidelines are 5 years old now, but it's just to highlight that salazine, sulfasalazine, steroids, thiopurines, anti-TNFs are safe in pregnancy. It is not the case that you need to avoid metronidazole in the first trimester. Obstetricians use this all the time to treat bacterial vaginosis, and in fact we prefer metronidazole to ciprofloxacin if, for example, you're treating pouchitis in pregnancy. These are guidelines actually prepared for primary care by rheumatologists. But as you know, many of the drugs used in rheumatology are similar to those used in inflammatory bowel disease. And this guideline is very useful because it divides drug use pre-conception, during pregnancy, and in breastfeeding. And it goes through the different biologic drugs. In the British Society of Rheumatology guidelines, there's an added column for paternal use, just to highlight that neither methotrexate nor MMF needs to be stopped in your male patients who are wishing to have a baby with their partner. So these guidelines are very useful to gastroenterologists as well. But the real issue with these drugs in pregnancy is keeping up to date with the data for biologics. So very briefly, to understand the issue with biologic use in pregnancy, you need to understand that the biologic drugs, the anti-TNF drugs, are IgG1 antibodies. They look exactly the same as a maternal antibody against pertussis, for example. And these IgG1 antibodies are actively transported across the placenta because they bind to this Fc receptor, and the antibody is thereby delivered directly into the fetal circulation. So an adalimumab molecule, for example, which is fully humanized, will reach concentrations in the fetus higher than in the mother by the third trimester. This active transport mechanism is more efficient the more pregnant the woman is. So for the anti-TNF drugs, we know that they cross the placenta, apart from certolizumab pegol, which lacks this Fc fragment, and levels in the baby are likely to be higher than in the mother if the biologic is continued throughout pregnancy. So on that background, it's worth looking at the Toronto Consensus statements for IBD in pregnancy, and they have two useful algorithms. This algorithm refers to the preconception assessment, and this divides the assessment into active disease and inactive disease. And if we just look at inactive disease now, it's very permissive in terms of not switching patients who are on 5-ASAs and thiopurines and anti-TNFs prior to pregnancy. Obviously, women on methotrexate need to have this therapy discontinued prior to pregnancy. And it goes through the issues that you need to discuss in pre-pregnancy counselling, For your patients on sulfasalazine, they need a higher dose of folic acid. Patients on mesalazine don't need that. You need to know about the previous obstetric history, and that is the time to have the discussion about the compatibility of their drugs and pregnancy, and come up with a documented plan for pregnancy. This other algorithm refers to induction therapy, and so again you can see that for anti-TNF use, it's permissive, and saying that you can use anti-TNFs for induction therapy in pregnancy, particularly in the first and second trimester. For the third trimester, it very much relates to whether what gestational age they are, but you can use corticosteroids and anti-TNF drugs to induce remission in pregnancy. But you guys come up with different drugs to treat IBD almost every week. And vedolizumab, we have some data for. So as you know, this is an anti-integrin. And early retrospective data, as with many drugs, suggested a low signal for congenital abnormalities. But these congenital abnormalities were all different. This is a very useful study published this year, and these workers looked at 29 centres from 9 European countries. There were almost 80 pregnancies where women received vedolizumab, and they compared these pregnancies with women taking anti-TNF drugs and conventional therapy. This first bar chart here shows you when the vedolizumab was used in pregnancy. So this is at conception, first, second and third trimester, and you can see that a lot of these patients were on 8-weekly maintenance in the third trimester. This yellow bar here refers to patients who stopped their therapy in the previous trimester. In other words, a lot of patients stopped the vedolizumab at the end of the second trimester, in other words, by 28 weeks. These two charts show you the use of concomitant medication in the vedolizumab-exposed pregnancies here. So these patients were taking mesalazine, immunomodulators, some were taking steroids. And this chart shows you the concomitant medication in the anti-TNF group, where they mainly weren't on any other medication. Some were on mesalazine, some were on immunomodulators. And these are the results. There was no difference in the number of congenital abnormalities in the different groups, or indeed the proportion of congenital abnormalities. And importantly, all these congenital abnormalities were different. In other words, there wasn't a pattern for vedolizumab or TNF-exposed pregnancies. And as you can appreciate from having gone through the pharmacology of the biologic drugs, the risk really is not congenital malformations. The risk is the baby born immunosuppressed. So we're interested in infections within the first year of the baby's life. And those two were not significantly increased with either the vedolizumab group or the anti-TNF group. In other words, there's no evidence that taking vedolizumab in pregnancy, particularly if stopped in the third trimester, increases the risk of neonatal infections. And these are the comparative table here, showing you the percentage of congenital abnormalities is the same in all groups, no significant difference, and no significant difference in the risk of infections within the first year of life. Which of your patients need a caesarean section? Well, it's usually not the job of the gastroenterologist to recommend caesarean section. This should be performed only for obstetric indications, except for the case of women who have particularly active perianal disease in the context of Crohn's disease, fissures and fistulae, particularly perianal fistulae. Pouches are a little bit more controversial. In my experience, it depends on the surgeon who's created the pouch. Some are very clear that they don't risk any damage to the external sphincter, for which women rely on their continence, and therefore surgeons will recommend an elective section in every case. But if, for example, you think of the woman who's had a previous vaginal delivery prior to her pouch surgery, then often she can achieve a second vaginal delivery with less risk compared to a caesarean section. So ask the individual surgeon, ask the obstetrician, and take both opinions into account. These are the statements regarding caesarean section from the Toronto consensus and from the ECHO statements. It's not an absolute indication, a pouch is not an absolute indication for a caesarean section. And here's the wording from the Toronto consensus statement. We do recommend cesarean section for women with active perianal disease. So the baby's now out, and you mustn't get confused about biologic therapy and vaccines. The issue here is live vaccines, and that is essentially rotavirus and BCG. Diphtheria, polio, pertussis and tetanus are all dead, and all babies should receive all of those vaccines. But if you have a patient who has had exposure to biologic drugs after 16 to 20 weeks, then the current recommendation for all biologics is that that baby should not receive BCG at birth and should not receive rotavirus. Now, delaying BCG until 6 months of age is fine. If you delay rotavirus vaccination until 6 months of age, it won't work. So depending on which biologic the child has been exposed to and for how long, you may wish to advise the woman to have her baby immunised against rotavirus at, say, 4 or 5 months of age. Otherwise, it won't work. Gastroenterologists are often very worried about performing endoscopy in pregnancy, but you shouldn't be. There's no evidence that a flexible sigmoidoscopy or even colonoscopy with full bowel prep will cause miscarriage. And if there is an indication, suspected cancer, wanting to assess inflammatory bowel disease, then you shouldn't deny women endoscopy in pregnancy, nor should you deny them an adequate amount of sedation. If anything, pregnant women need more sedation, not less, and you won't get a proper result if you don't use adequate sedation. You can, of course, nowadays use MRI to assess disease, and that's safe in pregnancy. We avoid CTs where we can. Similarly, for surgery, that should not be denied because the woman is pregnant, and I've seen, sadly, several cases where there is a delay in performing surgery, prolongation of large doses of steroids to treat very active ulcerative colitis, which ends up with a toxic megacolonal perforation. And although steroids are safe in pregnancy, they won't always sort the problem out, and they do often lead to premature delivery. So if surgery is indicated whether or not the patient is pregnant or not. We've got a few minutes for you to consider a couple of MCQs now, just to make sure you've been paying attention. So this is the first one. And in Crohn's disease, only one of these answers is correct. Seton suture should be removed prior to delivery. High-dose vitamin D should not be used. Adalimumab can be used when breastfeeding. Adalimumab used in the 3rd trimester means the baby should not receive pertussis vaccine. And adalimumab used in the 3rd trimester means the mother should not receive pertussis vaccine. So hopefully that's straightforward, and the answer is adalimumab can be used when breastfeeding. Next question, when managing colitis flare in pregnancy, cyclosporin should be avoided. Mesalazine should only be given with 5 milligrams of folic acid. Intravenous corticosteroids should be avoided if the mother has gestational diabetes. Oral prednisolone is preferred over dexamethasone. Progesterone should be given to reduce the risk of preterm labour. Well, I put this one in to trick you. Mesalazine, cyclosporin can be used. Mesalazine it's only sulfasalazine that needs the higher dose of folic acid. You shouldn't avoid corticosteroids with GDM. You just give insulin. And the correct answer is that oral prednisolone is preferred over dexamethasone because there is less transfer to the placenta. You can also use intravenous hydrocortisone. Now I'm going to talk about contraception because this is phenomenally important. This takes you way outside your comfort zone, but you are prescribing methotrexate to some of your patients, and therefore you may say something like, you cannot get pregnant while taking this drug, and the mother may hear, oh good, I won't get pregnant, I'll stop the pill. English is a very stupid language, and you have to be very clear that she understands what you actually mean is you should not get pregnant while taking this drug. And that question should then be followed up with, what form of contraception are you using? And the MHRA have issued guidance on contraception for women taking medicines that might increase the risk of birth defects. So this was really developed for valproate, but it's very relevant to those of you that use methotrexate and mycophenolate mofetil. You will notice that withdrawal condoms do not feature here. The highly effective methods of contraception are a copper coil, a Mirena, which is a progesterone releasing system in the uterus, or the progesterone progestogen implant called the Nexplanon. Those are very effective reversible forms of contraception. And so I've illustrated them for you here. This is the Nexplanon rod that goes on in the inner arm, the Mirena coil, and the progesterone pill. And this you can prescribe yourself. If you're prescribing methotrexate, it's no good writing a letter to the GP. You've actually got to make sure she is taking effective contraception. And in my last 30 seconds, to advertise a webinar that I'm running with 2 other obstetric physicians on the 25th of November. We normally run a 3-day conference, but this year it's virtual, it's 4 hours, each of us giving 2 talks, and the link to register for the webinar is theobstetricmedicinecompany.com. Thank you very much for listening. I'm very happy to take questions.
Thank you, Kathy. Thanks for that fantastic overview of a really important topic. And as you said, it's one where we're often outside our comfort zone. I'm Garrett Cullen. I'm a gastroenterologist in Dublin, and John Pierc is a colorectal surgeon also in Dublin. Where do you, or when do you think is the appropriate time to involve somebody like you when you have a patient with IBD who wants to become pregnant, or is even just having that first conversation about maybe thinking about having a family when they have IBD, particularly more complex forms of IBD where they're on a number of the biologic medicines?
I think it depends how confident the gastroenterologist and the team are in counselling her about the safety of those drugs. I mean, I work very closely. I work mainly at St Thomas's. They have a big IBD unit, and the doctors there are pretty confident in counselling women, so they don't refer that many women for pre-pregnancy counselling. And I might say that's in contrast to rheumatologists and dermatologists who are often using the same drugs. I think because gastroenterologists led the way with biologics, they've become more confident more quickly. And also their guidelines are much more, as I said in the talk, permissive. If you follow the guidelines, your guidelines say you can stay on your biologic, whereas the rheumatologists tell everyone to stop at the end of the second trimester. But against that, the small molecules, obviously, those need to be stopped. We have safety signals that are concerning for the small molecules. And I think if people are on things like vedolizumab, unless you have that data at your fingertips, you can't always confidently counsel women. So to answer your question, I'm very happy to see people if the gastroenterologist would find that helpful. But I think that there aren't obstetric physicians in Ireland, but there are very good obstetricians that you work with. But it's a question of forming a team, a link gastroenterologist, a link obstetrician, your go-to person, and together acquiring the expertise together with a clinical nurse specialist and a midwife, so that you have a team of people who can counsel women. And I think that's the. I mean, normally I would advocate you should have an obstetric physician in every unit, but it is possible, provided somebody knows which drugs are okay and what the issues are. It doesn't really matter whether that's the gastroenterologist, the obstetrician, or the clinical nurse specialist. But the woman we have to give consistent messages to the woman from all angles, because if she gets conflicting information, that's when the problems start.
Yeah, no, I couldn't agree. I mean, I think that's been a huge thing, certainly in the bigger centres in Dublin that I'm familiar with. The IBD nurse has been a massive improvement in that as a go-between, and that conflicting information from the obstetric hospital and ourselves a number of years ago was very problematic, and now we have this liaison in between, which has worked very well for us, I think. And also the fact that most of our IBD nurses are women as well has meant they've taken it on as an interest, and it's really developed to really improve care for patients. So John, have we any questions in from the audience?
Yeah, we've one question. Can you clarify what sedation you feel is safe in pregnancy for endoscopy?
Well, I would use midazolam if that's what you normally use. I think you should use the drug you would normally use that you're familiar with using. What you don't want to do is try and I've seen this so many times, oh, she's pregnant, oh, we'll do things a little bit differently, we'll give a little bit less, and then it all goes horribly wrong because you haven't given enough sedation. So give what you would normally give in the same or more amount, enough sedation to be able to do the procedure that you need to do. Clearly, if someone is in the third trimester and you're doing a top-end endoscopy, you've got a risk of aspiration and you'd use omeprazole or ranitidine. But when we're talking about IBD and colonoscopies, it's much more common to see that denied women and not get a proper diagnosis than to see it done. And I've never seen an endoscopy done in pregnancy and cause harm. I mean, if you think we do ELCPs and stuff at the top end in pregnancy for gallstones, you shouldn't be worried about doing a colonoscopy if the flexible SIGI doesn't give you the answer that you need.
I was in the rotavirus. Was interest the rota vaccine. Why doesn't it work after 6 months?
I don't know. I mean, I once listened to a talk by an immunologist, and I was none the wiser.
Okay.
I think it's something to do with the IgA development in the baby's gut. I don't quite understand it, but it's a real problem actually, because the virus has been introduced. The vaccine's been introduced because it works.
Yeah.
And so if you take, for example, the case of a woman who's had some adalimumab and she decides to stop at 28 weeks, the chance of that baby having significant adalimumab in its system at age 4 or 5 is very low indeed. But the rule is the rule, and the vaccine's alive, and these babies end up not getting immunized, which I think probably does more harm than delaying the immunization. For rotavirus would normally be 12 weeks, maybe giving that vaccine at, say, 4 months.
Yeah.
And furthermore, all this arose, as you probably remember, from infliximab and one baby given BCG who died of disseminated TB. So it's really the anti-TNFs, not the anti-integrins.
Yeah.
We don't fight rotavirus with integrin. So a woman on vedolizumab, for example, it shouldn't be a problem. But all of the drug companies have stuck with the same rule.
Yeah,
Even certolizumab pegol, which doesn't even cross.
Yeah. Yeah, no, it's a very helpful practical tip as well, because I know it has caused a lot of confusion. So we're going to wrap up that session, Kathy, but thank you very much for taking the time to talk to us and taking part in our virtual meeting and giving us a really great overview.
Pleasure. Thank you.
Take care. Bye now. So that wraps up our inflammatory bowel disease session, and I hope you all found it as informative and helpful as I did.